started in this business years and years ago. I guess it's business now, isn't it, under Trump? But anyway, when I first started in this business years and years ago, ventilators consisted of things that forced air into your lungs, and that was about it. We had this big new invention called IMV, and that was as high-tech as it got. Well, as we've looked over the years and learned more about how the lung works and realized that just shoving air into the lung isn't the right way to go, ventilators have become more and more sophisticated, to the point we thought it would be a good time to really talk about what we can really do with these things. So I don't need to introduce Steve. He's associate or professor of almost everything here.
Steve, that was an excellent introduction. So he saved me a slide. I have no disclosures, and this is very sad. So if anyone has any opportunities, I'm going to be talking about something I think which might qualify for a paradigm shift. Is that better? Can you hear me?
Yep.
Is it coming across?
There you go.
Okay, good. If it gets too low, let me know. A paradigm shift was a term that was introduced in a book by Thomas Kuhn in 1962. And the title of his book was The Structure of Scientific Revolutions. And he introduced this concept as a fundamental change in the basic concepts. In other words, it's a complete switcheroo of the way we practice and the way we approach things. And so hopefully by the end of the day, if you see the duck head, by the end of the lecture, hopefully you'll also be seeing the rabbit head. Or if you're seeing the rabbit head, you'll also see the duck head. Well, I'm going to be talking about severe respiratory failure, and I'm going to be focusing on ARDS. I'm not going to get much into the pathophysiology of ARDS today, other than to remind you that it is an inflammatory state that involves the pulmonary parenchyma, as well as the pulmonary capillaries, results in development of inflammation, upregulation of the inflammatory state, and fluid exudation into the alveoli, so the alveoli get filled with fluid, not just collapse, but they get actually filled with fluid. They also get filled with cellular debris, and if you look at severe ARDS under a microscope, you may see retained alveolar structure with fluid, but you also may see it filled with cells. And therefore, these alveoli are not very amenable to being ventilated. But this is the driving force for my lecture. Ventilator-induced lung injury is a concept that actually began to form, and some early work was done as early as 1965. So we're talking 50 years ago now? Did I do the math right? 50 or 60 years ago. And over the next 4 decades plus, there was a data accumulating as to the fact that indeed ventilators can induce lung injury when we apply it to patients who have underlying respiratory failure. But it wasn't until a clinical trial that I'll go over, which translated that into clinical practice and made everybody believe it. Nobody believed it. It was all animal trials for 40 years, even though these trials were fairly convincing, but it took a clinical trial that I'll go over briefly. But anyway, ventilator-induced lung injury has features of ARDS. It looks just like ARDS on the X-ray, histologically, so you can't distinguish ventilator-induced lung injury as a cause of respiratory failure from anything else. And that's probably why it crept so far along without being recognized, because you'd get a patient, you'd put on a ventilator, we'd crank I remember having a peak pressure at one time of 100 centimeters of water, and we were kind of proud of that. And then the patient would get worse, and we would say, oh, they just say ARDS getting worse, we don't have control of the source, blah, blah, blah. But in fact, we were probably killing these patients. Just briefly, we're going to talk about some value trauma. Value trauma being the over-distension of alveoli that can lead to mechanical injury. Adolect trauma, which is an opening and closing of atelectatic areas, and that repeated opening and closing exerts tremendous shear forces during that process. That can also lead to mechanical injury. And these two sources of mechanical injury get transduced into the activation of the inflammatory response, which can be both local in the lungs as well as systemic. And it's been demonstrated in animal models that ongoing ventilator-induced lung injury can cause multiple organ failure and death. So, having said that, this is not an atypical X-ray in a patient with ARDS, and one of the early definitions of ARDS includes diffuse infiltrates, diffuse in all of the lung fields. And we were also kind of approaching our patients with the concept that this was a diffuse injury. But in the vast majority of ARDS patients, this is not a diffuse injury. This is an injury which has the influence of gravity. This is a typical chest X-ray of ARDS. This one was induced by sepsis. We see what looks like collapsed lungs down here. Okay? But these are not collapsed lungs. These are lungs that are filled with fluid and cellular debris. There might be some atelectasis here, and then we have aerated areas here. Notice these aerated areas are small. One of the early approaches to ARDS, one of the early concepts or ways that we thought about it was that the lungs would just stiff. And that if you just crank up the pressure, you would open up the lungs. Okay, that was a false assumption. That assumes that all of the lungs could receive air and all of the lungs had poor compliance. What Gatnoni and others have demonstrated is that we actually have little baby lungs that are normally compliant. They're just small. And we have areas of the lung which are non-ventilatable. So if we try to recruit these lungs, if we try to recruit and open this up, it's not going to work. And what we'll do is we'll cause damage to these small lungs. In the average severe ARDS patient, the volume of these lungs is 25% of normal lung capacity. So if you were to take 10 cc's per kilogram, which is the way we used to ventilate our patients, say for an average adult, 700, 800, even a liter tidal volume, and you would throw it into a space which is 1/5 the size of what it used to be, you're providing an equivalent of 40 or 50 cc's of tidal volume. So for those that are used to tidal volume, you know that scares you because you know that will cause damage. And we were doing it because we didn't know better. But now we know better. We now know that we have to ventilate these tiny lungs. The clinical trial I referenced earlier was we call it the ARDSNet trial. There was a multi-center trial conducted by the ARDS network, which compared two tidal volumes. It compared a traditional tidal volume, which in the textbooks at that time said 10 to 15 mils per kilogram, so they picked the middle of the road of 12. And then they picked somewhat arbitrarily, no, there's really no basis for it, but arbitrarily picked half of that as 6 mils per kilogram. And randomized patients with ARDS to one of these two tidal volumes. They also adjusted PEEP based on the FiO2. So if you had an FiO2 requirement of 1, you had very high levels of PEEP, 18 to 24. And also, because of the lower tidal volumes, if you began to get hypercapnic, that would increase the respiratory rate. So I'm going to show you why this is not a good idea, this is not a good idea, and why, even though the ARDSNet trial was an important landmark, and many have taken it to become a protocol for managing patients, it is clearly not that. So I'm going to support the ARDSNet trial as showing and demonstrating a hypothesis, which is clearly important, but I'm going to debunk it as a protocol for managing patients. So in this trial, the smaller tidal volume showed a decreased mortality, more time off the ventilator in those who survived, and a decreased multiple organ failure. Remember I mentioned earlier that ventilator-induced lung injury, if allowed to persist, can actually impact extrapulmonary organs. And even though the oxygenation was a little worse and the PCO2 was a little higher and a little more acidotic, in other words, we allowed their physiology to get a little worse, protecting the lungs still bore out this decrease in mortality. And these are the survival curves that show the difference right up here. They looked at survival out to 180 days. Data was, other studies have come out, and this one I just put up here to show that the low tidal volume ventilation here, which averaged about 6.5, but even had more traditional lung volumes, had an impact on mortality out to 2 years. Okay, so it's not a short-term mortality improvement, it's a long-term mortality improvement. I want to show this. I've got these slides backwards, excuse me. This group looked at CT scans and made measurements of lungs that were more protected or less protected based on the amount of air in the lungs. So if the lungs were over-distended, therefore less protected, they had a higher ratio of air to tissue, and the Hounsfield units on the CT were a little different, as opposed to patients that had a more appropriate amount of air. And he was able to identify in a group of ARDS patients, ventilated with 6 mils per kilogram, that there were a number of patients who were properly protected at 6 mils per kilogram, but there were still a number of patients that had CT evidence of hyperinflation, therefore less protected. So even at 6 mils per kilogram, it began to be realized, hey, you know, this may not be good for all patients, and we may even have to go lower. And in this less protected group, it demonstrated a higher concentration of inflammatory cytokines. So it was not just an observation, it was actually translated into pathophysiology. So a trial was done that looked at tidal volumes lower than 6 mils per kilogram, 4.2 on the average. When you get down that low, you begin to accumulate carbon dioxide. So they took that out using extracorporeal CO2 removal to help normalize the PCO2 despite the lower tidal volume. And they were able to show improvement in morphologic markers as well as improvement in the release of pulmonary cytokines. They did not demonstrate at that time any change in mortality, but it wasn't powered to do so. They did show a reduction in ventilator-free days in the more severe group. This was applied to all ARDS patients, but in the more severe ARDS patients, it translated into being able to come off of the ventilator faster. So we're getting a signal here that there may be patients that may do better with lower tidal volumes, even than the 6 that has been thrown around. Looking back at the ARDSNet data again, and plotting the plateau pressures in the two groups, one can easily see plateau pressures higher in the high tidal volume group, but interestingly, this kept getting higher and higher and higher. What does this suggest? This suggests that there's worsening lung injury in this group. Down here, the pressures were lower in the order of the 20s, and they stayed relatively stable, indicating that this slope right here is not very high, indicating that it was fairly protective over time. So the ARDSNet data was looked at again, and this time it was looked at from the perspective of the pressure that was used to inflate the lungs, not just the tidal volume. It demonstrated a clear relationship between inflation pressure, which is they defined as plateau pressure, and mortality. And this relationship went all the way down to about 10 centimeters of water, which is fairly low pressure. And so this began to raise the question, are we really targeting the right thing when we're targeting low tidal volumes in our patients with ARDS? This was a subsequent study that was published that looked at 9 published studies and put the data together and again looked at driving pressure. Here, instead of plateau pressure, which is the peak pressure at the end of inspiration, they looked at driving pressure, which is the pressure above PEEP. And it demonstrated a similar relationship. The lower the driving pressure, that is all the way down to 7 centimeters of water, the lower the mortality. Okay? And this was relatively independent of tidal volume. Here are the tidal volumes down here. This is 6 mils per kilogram. This is still 6 mils per kilogram, and this is only 8 mils per kilogram. So the signal appears to be that we want to pay attention to inflation pressure, not inflation volume. And that's kind of the paradigm shift I'm talking about. Because after the ARDSNet trial, there was the ARDSNet protocol that was used for the research paper that then began to be followed in patients in the ICU, even though that was not the intention of the study. Now, what you see here are scanning electron micrographs of alveoli having been exposed to only 20 centimeters of water inflation pressure. We don't think anything about 20 centimeters of water, do we? And that's after 5 minutes of exposure to just that level, we can see mechanical injury to the alveoli and loss of type 1 alveolar cells. So the point of this slide is it's very, very easy to injure lungs with mechanical ventilation. I don't think we fully appreciate how easily we can do that. I want to jump now into some equations. I'm going to start off with this equation here. This is the equation of motion during breathing. This is classic physiology, 1950, okay? This was when some classical physiologists looked at what went into causing lungs to expand and contract. So this is pressure. This is elastance, which is the inverse of compliance. So if you have a highly if this goes up, you have a stiffer lung. So if you have a stiffer lung and you try to put in a higher tidal volume, you can end up with a higher pressure. Then it looked at the resistance components and laminar flow, which is related to the flow rate, and the turbulent flow, which is related to the square of the flow rate. And these were just observational studies, not so much intended for clinical use at the time. But they were rejuvenated by Gattinoni very recently. And he modified the equation of motion that Otis and Ron put forth. What he did was he got rid of the turbulent component of the airway pressure, so we're just left with the flow and the airway resistance, but not this laminar, not the turbulent. He kept this component, of course, and then he threw in PEEP. He says, because even though this is the driving pressure, the total pressure applied is going to include PEEP as well. Now, technically, that is no longer an equation of motion because PEEP is a static pressure applied. It's not motion, but that's why I call it modified. But that's what. But Gattinoni added that in. Then he added in. He integrated it over the tidal volume to determine how much energy we are transferring to the lungs with each tidal breath. And this E represents energy. This is elastance. And now we see that the energy is related to the square of the tidal volume. Meaning the tidal volume has a pretty important role in transferring energy to the patient. The airway resistance component is still there. It's modified by the inspiratory time because the shorter the inspiratory time that you try to get air in the lungs against a fixed resistance, the more energy you have to expend. So he's including this airway resistance term in flow term as well. And that's we'll see how that could be important. And then he's throwing in the tidal volume times the PEEP as well. And then he threw in the respiratory rate. And what that gives us is the mechanical power transferred to the lungs over a period of time. So if your respiratory rate is per minute, this is how much power is transferred over the course of 1 minute. And here are the key components. Respiratory rate is directly related to the power. If you double the respiratory rate, you double the amount of energy that's delivered. If you have lungs that are stiffer and you try to throw in a higher tidal volume, then that tidal volume effect is squared. So doubling the tidal volume gives you 4 times as much energy applied to the lungs. And I think that underscores the importance of trying to keep that low. Now here, PEEP and tidal volume exist. This suggests that the higher the PEEP, the more power we're transmitting. And we know from many, many clinical studies, I'm not going to get into all of them, or maybe not most of them, we know that patients do better with higher PEEP. So how do we wrestle with that? And that's because PEEP and elastance and airway resistance are all interrelated. As you increase PEEP, you will actually alter elastance, and you can alter airway resistance. And there's an optimal PEEP that optimizes the mechanical properties of the lungs. So while there is a higher power applied, this modifies particularly this one and somewhat this one, so that we can't look at PEEP directly as contributing right here. Okay. So the things we have to pay attention to are going to be tidal volume, inspiratory time, respiratory rate. And then we have to pay attention to PEEP that may fall outside of any values that are that will optimally set up the lung for appropriate mechanical ventilation. Okay? And let's take a look at this study, this is a lung safe study, which was recently published, which is an observational study from 2014. 459 ICUs, 50 countries, almost 2,400 patients with ARDS, collecting data to see what impact does respiratory rate have, tidal volume, PEEP, driving pressure, and plateau pressure. And these are patients stratified by mild, moderate, or severe ARDS. And we can see that tidal volume really didn't have any impact on mortality, low versus high tidal volume. PEEP and moderate ARDS had an impact. Respiratory rate had an impact, I'll show you in a second. But driving pressure clearly had an impact. So here, tidal volume did not. Driving pressure and plateau pressure did, especially in the severe ARDS. Respiratory rate, P equal 0.003. Higher mortality with higher respiratory rates. We haven't been paying attention to respiratory rate. I mean, I have, because I did a study back in the 90s, an animal study, which looked at the impact of respiratory rate on the development of ventilator-induced lung injury. And I don't have the slides up here, but showed that you can help protect against it by lowering the respiratory rate. So I've always been a proponent of respiratory rate, but that was based on animal studies. Now we have some clinical evidence to show that we should pay attention to respiratory rate. A higher PEEP was associated with a better outcome and a lower peak inspiratory pressure. So this is just further evidence. Get away from targeting tidal volume in our ARDS patients and targeting driving pressure and plateau pressure. Okay. This is another study that showed that higher PEEPs did better. This was a PEEP level of 9 versus 15 in severe ARDS. So again, supporting the concept that you need an adequate PEEP in order to optimize the mechanical properties of the lungs. But what this study did is it showed high versus low PEEP. It did not adjust the PEEP for each patient. Similar to the ARDSNet trial, where it was a high versus low tidal volume, but did not adjust the tidal volume for each patient. And the showing also that there was a lower, in ARDS patients, there was barely significant, but a lower in-hospital death, as well as ICU death associated with the higher PEEPs. So we have to have some PEEP. What we don't have is a good study that tells us exactly how we need to set it. So my recommendations on PEEP that I'm going to tell you are based upon what we know about the first principles applied to lung injury. To lung mechanics. So lung protective ventilation, which we used to say high respiratory rates, high PEEP, low tidal volume, fixed at 6 mils per kilogram, I think needs to change. Because there has been no level of mechanical ventilation that's been shown to be safe. And safe is not really dichotomous. You can't go to a patient, put them on 6 mils per kilogram and say, okay, this patient's on safe ventilator settings. The injury to the lungs occurs at all levels of applied force from the mechanical ventilator. And so it's not a dichotomous treatment effect, but rather you want to stay as low as reasonably achievable. I want to talk about applying how we ventilate our patients with respect to volume versus pressure targeted ventilation. Obviously, I'm biased. I should have put this in my disclosures. I'm biased towards pressure, but I'll show you why. Pressure has a number of potential advantages over volume control. Now, volume control, and I'll explain what all this means in a minute, was used in the ARDSNet trial. Even though it was used in the ARDSNet trial, I don't practice it. And it has these characteristics, which I'll show graphically what they mean. Decelerating flow pattern, lower end inspiratory flows and mechanical stress, and a higher time average tidal volume. But here's, I think, the key part of this slide I want to bring in. I mentioned it'd be nice to be able to target a tidal volume to a particular patient. What makes sense, based on the equations of motion that I showed you, is that you want to target a tidal volume appropriate for the elastance or compliance of the lung. What is compliance? It's volume divided by pressure. What is pressure? Volume divided by compliance. So pressure is compliance-corrected volume. Okay? That's a very straightforward analysis of units that show you that if you want to target your tidal volume and correct it for your patient's compliance, you want to target pressure. Okay. Also, I'm biased towards the use of supported ventilation. There's a number of studies that suggest that in the appropriate patient, supported ventilation has a number of advantages, including hemodynamic improvements, improved oxygenation, and has been shown to be less inflammatory than controlled ventilation. So a supported ventilation helps to track. It tends to follow the patient's needs. It tracks their inspiratory flow, it tracks the inspiratory time, whereas controlled ventilation says, I'm going to give you an inspiratory flow and I'm going to give you an inspiratory time. And the patient has to adapt to that. Now, it doesn't matter how you apply the ventilator, whether it be a volume-limited approach, a pressure-limited approach, a pressure control, or a pressure support. If the patient is not synchronous with the ventilator, you can still get lung injury. And studies have shown that supported modes are more synchronous than control modes, but even in supported modes, one can still get injury. And here's the reason. If you, this is controlled ventilation with a paralyzed patient. Okay? This is comparing control versus assisted, and they're trying to say controlled ventilation is better, but that's only if the patient is completely synchronous. This can happen either in controlled or assisted ventilation. So what I'm referring to is the fact that if you're applying a positive pressure into the lungs, for example, 28 centimeters of water, and the chest wall, the patient is not expanding the chest wall, then you can have a positive intrapleural pressure, say, of 10 centimeters of water, and so your transpulmonary pressure is only down to 18. But if the patient actively tries to inhale against the flow that the ventilator is trying to deliver, and it's not delivering enough, then that pleural pressure can become negative, say example minus 10, and we've doubled our transpulmonary pressure, which is the pressure that's distending the lungs. So this is just one quick slide, but the major point is we have to pay attention to our patients and make sure that they are synchronous with our ventilatory approach. Okay, so actually this is ventilator dysynchrony. Okay. Another thing we haven't paid a whole lot of attention to, even though there's a fair amount of literature on it, that is ventilator-induced diaphragm dysfunction. Without going into all these details, mechanical ventilation if it's used to offload the work of breathing, in other words, the patient lets the ventilator do all the breathing and all the work for them, then through a variety of pathways, we end up with muscle proteolysis, myofiber atrophy and injury, and decreased muscle cell protein synthesis. And we end up with a diaphragm and intercostal muscles that have myofiber atrophy and no longer can function appropriately. So these are actually phenotypical or morphologic changes that occur in the diaphragm when they are not working, okay, for a period of time. This is been demonstrated in other studies. So what the takeaway from this is you need to appropriately load the diaphragm in patients who are on prolonged mechanical ventilation. Otherwise, they will develop this muscle atrophy if they don't do any work. And of course, if they have an inappropriate level of ventilatory support, then they end up with this problem here. So it's a fine balance between the two. I did mention I'm a fan of supported spontaneous ventilation, which is a pressure support ventilation with an appropriate PEEP. It maintains an elevated mean airway pressure because of the PEEP. Tidal excursions are now set by the patient. So I think this is really cool. Now the patient can set their tidal volume. Okay? Instead of you saying, I think this is best for the patient can set their tidal volume. And they do that with feedback from the stretch receptors in the lungs and so forth so that they avoid injury. And I've never found any study except one that showed that a spontaneously breathing animal, not a human, an animal, developed lung injury. And that was when there was an artificial induction of a high respiratory drive. And there's also studies to show that it has good impact on VQ matching and less impact on cardiovascular function. But from a practical standpoint, we can help minimize our sedation because it's easier to get patients synchronized. They maintain their respiratory muscle strength, which may let us get them off the ventilator sooner, may make them less prone to ventilator-associated lung injury and less prone to diaphragm dysfunction. But remember, any patient is still susceptible to dysynchrony. So my approach to mechanical ventilation and ARDS when I'm using conventional mechanical ventilation is to add in PEEP. And what I try to do is to obtain a static pressure compliance, a static compliance curve to see where I might want to adjust my PEEP, because I'd like to optimize it to make sure I have an adequate level of PEEP. In the absence of that, I tend to keep it generous, 10 to 15, that says 10 to 12, but I may go high as 15 centimeters of water. You don't really have to do a formal static compliance curve to see the effects of PEEP. If you put the patient on a fixed inflation pressure, then you adjust the PEEP, just watch their tidal volume. As you raise PEEP and their compliance gets better, the tidal volume will get bigger. And as you go higher on your PEEP, your tidal volume will get smaller. It's very simple. So that's how I adjust it. If that information doesn't help me, if the patient maintains a consistent tidal volume, I'll set it at 10 to 12. Limit your driving pressure typically to 12 centimeters of water because you want your plateau pressure low. Okay? I say less than 20. It used to be less than 40, then less than 35, then less than 30, less than 28. I'm saying now less than 24. Okay? And no tidal volume target. All right, some ventilator waveforms for the next few minutes. This may be of more interest to the residents or disinterest to the residents and fellows, I don't know, but it's going to explain some of the principles. I talked about volume control and I talked about pressure control. And one of the reasons I like pressure control was its decelerating flow pattern. Well, this is a graphic representation of that. On the left is constant flow. Volume control mode on the ventilator gives you a constant flow. The flow shoots up to a target value, holds it constant, and then drops off. Boom. And then here's the expiratory phase. A decelerating flow runs the flow up higher, but then allows it to come back down to baseline. Now you either have to go to the tidal volume delivered. If you remember physics, volume is flow integrated, right? So if we integrate this flow, which is the area under the curve, that is the volume delivered. So if we have the same inspiratory time and the same peak flow, we can only deliver half the tidal volume. So on decelerating flow modes, you have to go to a higher initial flow or a longer inspiratory time in order to get the same tidal volume. Just a little bit of physics. We also, on the ventilator, can select whether we want time cycling or flow cycling. So this is our control mode, and this is our support mode. Control mode says, I'm going to give you a fixed inspiratory time. If you want it longer, you want it shorter, that's tough. You got to deal with it. Support mode gives you flow cycling, where the patient says, okay, I'm done breathing, I'm going to start exhaling, and then it picks that up and it cuts it off. So flow cycling may actually continue to still have flow for a percentage of the at a percentage of the peak inspiratory flow. And this is adjustable. We can adjust it way down to give the patient a longer inspiratory duration of support, or shorten it. So given these two slides, this one and this one, I will submit that a ventilator has only 3 basic ways to deliver gas to a patient. So that keeps things kind of simple. Yeah, the inspiratory flow pattern, which is constant flow, which is a volume control mode, or a pressure control mode, which is decelerating flow. And then you can adjust, you can change the expiratory cycling, which is done through your control mode versus your support mode. And you end up with only 3. This one doesn't exist. But volume control, pressure control, and pressure support. And that's the only 3 ways a ventilator delivers gas to a patient. But if you look at the front of a ventilator, you've got 12 modes, right? And we'll talk about those. So I did mention an advantage of decelerating flow, and I'm going to explain why that's advantageous. Okay, here is a volume control ventilation, constant inspiratory flow, and so a constant rise in airway pressure as flow is delivered. And then exhalation. On pressure ventilation, we have to go to a higher initial flow in order to maintain the same tidal volume. So you see that the pressure shoots up more rapidly, but then plateaus off. Okay? And this plateau represents the decelerating flow down to 0. Both of these have the same tidal volume. Correct? Everyone agree? If that's, say that's, same inflation pressure. However, look, and the same tidal volume. But if you look at the area under this curve and the area under the volume curve, the area under this curve is higher than the area under this curve, because it front loads the tidal volume and keeps it going. That means you have, over the course of the respiratory cycle, you have a higher mean average tidal volume at the same peak tidal volume. More bang for your buck. That's why pressure control can give you a little better ventilation and perhaps a little better distribution of gas than a volume control. So there are first principle reasons to go to a decelerating flow. The other modes, I'll just go through them very quickly because they're all combinations of the 3 basic modes. IMV is an alternation between a control mode and a support mode, whether you do it on a volume control or a pressure control basis. So the patient switches from I'm going to control your breath to you control your breath. I'm going to control your breath to you control your breath. Popular in the 80s, and it's still used today. But I don't see any advantage in it because I'm going to pick one of these 2 modes. APRV gives you a pressure control It's a very long inspiratory time, but with the expiratory time, it's basically a controlled, pressure controlled breath. It's just you're shortening the expiratory time to limit the volume loss in the lungs. And then you're allowing pressure support on top of it. So APRV is pressure control plus pressure support. The pressure control is so extended that for the most of the inspiratory cycle, APRV works just like pressure support. And it's only during that short expiratory time to help with CO2 removal that it impacts it. And remember, when you have that long of an inspiratory time, you're raising your mean airway pressure up almost to that level. So you can effectively consider the high pressure component of APRV as a PEEP. Like effectively, that's the PEEP that the patient is getting. Volume support is it's a misnomer. It's actually a pressure support, but it's volume targeted, so it delivers breath in a pressure support mode. And PRVC delivers in a pressure control mode, but it's got feedback. Both of these have feedback to change the pressure to adjust your target tidal volume. So volume support and PRVC are not volume targeted, not volume assured, they're volume targeted. And then auto mode is just switching back and forth between a control mode and a support mode, depending on the patient's respiratory drive, okay? I just have 3 more slides and we'll call it, 3 or 4 more slides and we'll call it a day. I want to look at the work of breathing. Because when we talk about providing patients and offloading their work of breathing appropriately, you need to understand how the ventilator ties into the work of breathing. This is spontaneous breathing. This is a transpulmonary pressure. This is negative, meaning that the patient is generating a negative pressure breath. And on the inspiration, as the pressure gets negative, volume goes up, and then you have the expiration. And the work of breathing is the area under this curve. That's to one side here. So this is spontaneous breathing. This is the work that the patient is doing. Now let's say we give our patient a paralytic and we put them on controlled ventilation so they're not making any effort whatsoever. Then the ventilator does all the work of breathing. Okay? And the patient's doing none. So that's one of the reasons I'm not a fan of IMV, is because you either got this or you have that. You don't have any fine control of offloading the work of breathing. So let's look at supported ventilation, and I'm putting low-level support here. So here it crosses the line. So the area under this curve to the left is the work done by the patient, and the area to the right is the work done by the ventilator. And this is at a lower level of pressure support. We can tweak, as we raise pressure support, we shift this curve to the right. So we go to a little higher level support. We now have the ventilator doing most of the work and the patient doing much less work. So one of the advantages of a supported ventilation is that you can tweak and adjust it so to give your patient more or less. But the advantage is it still allows the patient to do some work of breathing. And that, as I mentioned, is important to maintain diaphragm function. Okay? I don't like IMV because what it does is it flips you back and forth. There's some pressure support, so the patient still does, the ventilator still does a little bit of work during the pressure support breath, but during the controlled breath, it flips you to the right. And I just can't comprehend how flipping that back and forth is in any way good for the patient. But that's just my bias. Okay, so I'll summarize. The goal of mechanical ventilation in severe lung injury is twofold. We have to balance 2 objectives. One is we have to make sure we get enough gas exchange, otherwise the patient's not going to survive. But we have to minimize the injury that the ventilator may induce. I would submit that pressure-targeted ventilation strategies individualize tidal volume delivery to the individual's mechanical lung properties. Okay? Contrary to the ARDSNet, my recommendation, as has been shown in other studies before ARDSNet, is that PEEP should be titrated to lung mechanics, not oxygenation. That is, don't follow the ARDSNet protocol for PEEP. Supported ventilation, as opposed to mechanical ventilation, it's controlled ventilation, appears to reduce applied mechanical stress, allows partitioning of the work of breathing, helps to maintain diaphragm function, and may reduce mechanical stresses and lung injury. Recognize that ventilated dysynchrony in any mode you ventilate a patient can undermine any lung protective strategies that you take. And then failure to maintain low inflation pressures is an indication for additional measures, where you want to implement prone positioning. It's probably the only proven option we have. And then if that fails, moving on to extracorporeal support. Okay, with that I'll conclude. And I'm right on time, and I'll answer any questions.
Really enjoyed your talk. I have a question about, have you had any experience in using CAM in order to deal with the CO2 issues, speaking from your experience in your patient population?
Not anymore.
Because you tend to go to AirCore or ECS.
Yes, we would, I'll tolerate some degree of, before I go to extracorporeal support, I'll tolerate hypercapnia. Just because the PCO2 is 60 or 80. And it really depends on if it's hypercapnia at safe lung pressures. Okay? Usually hypercapnia is associated with difficulty ventilating patients, and they have you're applying higher pressures. And so I go so much on, can I support that patient with an appropriate level? Can I get my peak inflation pressure down to 20 or 22 or 24 and at a PEEP of 10, 12, 13, 14? Can I achieve that? If I can, and there's hypercapnic and it doesn't appear to be causing any problems, I'll tolerate that. If I can achieve that, but I think the hypercapnia is causing problems, I'll go to extracorporeal CO2 removal. But if I can't get my pressures down, no matter what the PCO2 is, then I'll go to ECMO.
So I don't know whether this is great minds or sick minds think alike. My question was very much like Dr. Sanders, which is, we have lost them, unfortunately, in the United States this year. And no matter how you cut this up, the lung protective strategy is going to decrease minute ventilation. And that's going to result in a drop in the pH. And it's been shown that until you get to about 7.2, PaCO2 is probably irrelevant. And what we're left with is bicarbonate, but of course that then just is chasing your tail because you're going to produce more CO2. And so then that brings me to my question is, in the trauma patient who comes in with pulmonary contusion and defective chest wall and defective respiratory musculature, what do we use to bring us back into a safe pH when we're using what amounts to intensive hypercapnia, which may be, I don't know if that's a term that's even still used anymore, but in essence, it's part of this equation.
Yeah, it's PAM is, if you don't know, is a buffer that can raise the pH but does not produce carbon dioxide. So what he's referring to is if you have a high PCO2 and a low pH, why not give them a buffer, raise the pH, which may help them tolerate the higher PCO2s because you're correcting the pH. You're improving enzyme function and so forth.
Cardiac.
Cardiac function. If you give bicarbonate, which is our only other available buffer at this time, the reaction releases carbon dioxide rapidly, which goes intracellular, causes intracellular acidosis. So I used to be a fan of buffering. I'm not so much anymore because now that I have, it's so easy to do extracorporeal CO2 removal where I can fix both the pH and the PCO2. And remember, PCO2 still has issues in the brain and so forth. So my approach now for hypercapnia is if it gets to where the pH is not tolerable, I personally don't go to buffering. I still think it's an option. The only thing we can buffer with is bicarb, which means you have to do it slowly, so you don't, and which takes a long period of time, so you can excrete the CO2 as it's produced. It may take hours to try to buffer somebody up. But my approach is just extracorporeal CO2. Now, we primarily use arteriovenous here. I don't like sticking an artery, but right now it's so easy to do arteriovenous. There's no pump. You just put the patient on it, throw it under the bed, and the sheet, under the covers. But there are on the market, and coming for too long, little small units that will do venovenous CO2 removal, just like hemodialysis machine. We stick in like a 15 French dual lumen fem catheter or IJ, doesn't matter where it goes. Put them on this machine and it'll remove the CO2. So that's another technology that's available in other countries, but not here, and it's undergoing an approval process in the US. So I think that we'll be able to get rid of arteriovenous CO2 removal and go with something like this. And then those where you can't keep the patient oxygenated at safe levels, then extracorporeal membrane oxygenation, where you provide oxygen as well as CO2 removal. Okay, so keep in mind those pressure targets. Just remember, the higher you tweak it up to try to get by, the more injury you're producing. So,
while you're here, do you think there's any possibility for the return of the fluorocarbons?
The answer is the fluorocarbon is a very good theory. Fluorocarbons are heavy, for the audience, are I don't know, 20 carbon chain or something, 18 carbon chain. Carbon chains that have a fluorine instead of hydrogen attached. And they have very high gas solubility capabilities, and they're very dense, and they have a very low surface tension. So there was a trial to look at using this to help support patients in the ARDS. And we actually we're one of the 3 or 4 phase 1 centers that did it. We did what was called partial liquid ventilation. Partial liquid ventilation is where you fill the lungs with fluid and you ventilate on top of it. Total liquid ventilation is where you fill the lungs with fluid, and if you've seen The Abyss, and you breathe the fluid in and out. Okay? The mouse thing in the Abyss, did everyone see that scene? Where they dunk the mouse in the mouth of breath? That was real. But him breathing the liquid, that's not real, because the liquid is so heavy, you'll exhaust yourself after a short period of time. So tidal liquid ventilation is probably ideal, but it requires a liquid ventilator. And still there are problems in getting enough convective flow to get rid of CO2. So I don't know its future. But what it does do is, because of its surface tension, it will go into the lungs. It will open up all alveoli. Okay? You're filling the alveoli back with lungs, like when it was in amniotic fluid. And so you don't have to deal with atelectasis. All the alveoli are open. And the liquid exchanges gas very readily, but you have to get gas to the liquid. So the partial liquid ventilation, where we fill the lungs with fluid and then gas ventilated, it worked in terms of ventilating the patient and oxygenating the patient. However, it reduced some barotrauma, because you got FRC full of fluid and then you're throwing in tidal volume. Now maybe, not knowing what we were doing back then, if we repeated that trial using lower tidal volumes, we might be more successful. But I think partial liquid ventilation is not on the radar anymore, but total liquid ventilation is still under research at some centers. And the stuff is excellent for lavage. When we put it in our ARDS patients, everything in the alveoli that was not attached came up. And so the mucus, the dead cells, everything was just lavaged right out without us even trying. And the fluorocarbon, the same fluorocarbon we use, is trying to hit the market as a lavage agent. He's been dancing with the FDA for 1 or 2 years. The guy that is bringing it back out bought the rights to it from the original company, and he wants to bring it out. It's in other countries as a lavage fluid, but it'd be nice if we could get it back here, because I think it'd be an important adjunct in the management of our ARDS patients. It has anti-inflammatory effects. It has a number of beneficial effects, although using it purely for liquid ventilation is probably off the table right now. That's a long way to answer your question, but I wanted to give the audience an introduction to that. Okay? I think we're cool.
Steve, thank you for that wonderful review, and I hope the audience realized what a treat we have had to benefit from his 40 years of hands-on pulmonary work. It's truly outstanding. One practical question, I think it's practical. The companion to mechanical ventilation is suction. And while we're talking about injury to the lung, do you think that suction can be an injuring agent to the lung? Are we denuding the tracheal?
I don't think it's harmful from a perspective of the actual suctioning of the secretions or the trachea, but what it does is you decompress the airway. So if you have someone who's on PEEP and you apply suction, boom, you drop their PEEP to 0, you collapse their lungs. So the answer is it can be harmful. And to my knowledge, it's not been quantified in that perspective. But one of the things I put on my slideshow is that one of the advantages of keeping a patient more awake, less sedated, and on a supported ventilation is that they can cough. And when they can cough, you're not having to go in and suction as often. You're going to have to tend to suction more of the endotracheal tube to keep it clean. But they do a pretty good job of coughing. Because we used to manage our patients with ARDS, and especially on ECMO, we would do bronchoscopies almost every day. Because we had these patients sedated and paralyzed. And secretions would just build up that weren't amenable to plain suctioning. So we were going with a bronchoscope every day, every other day, and just sucking out mucus. Now, with our patients awake and interactive, they're coughing, and we don't have to do that anymore. Okay. Thank you much.